contamination. So the easiest way to avoid contamination is not to let me see the Ohana support intervention if I'm not in that group. So everybody in another community was given the standard intervention. Only the people in a different community were given the Ohana support mechanism. So the big advantage of assigning people in communities to one treatment arm versus another is to avoid contamination. We do that all the time in clinical trials in our hospital. We want to see if we can change the way doctors practice medicine. We want to see if one new intervention, giving doctors new information electronically, lets them treat their patients better. Well, if I'm a doctor and some of my patients are being assigned to a new treatment,
yeah. Fran, I think we lost you there for quite a while. Sorry, Fran, we lost you there for quite a while. Could you back up?
I'll go back. Did you hear me talking about the advantages of community versus individual randomization?
I think we heard you through almost that whole part. You could back up to about.
So let me complete the thought I was talking about. I was talking about the community interventions or intervention by groups is also done a lot in clinical studies at my hospital. We might want to know, for example, if a new way to practice medicine, like feeding information electronically to physicians about their patients, might improve the way they practice medicine and improve the care that their patients get. So one design would be to randomize patients. I'm a doctor, I might have 10 patients in this study. Maybe 5 of my patients are being randomized to this new mechanism of treatment and 5 are randomized to standard of care. But since I'm caring for all 10 of these patients, I'm going to see the intervention. I'm going to see if it's working on these 5 patients of mine who are randomized to receive the intervention. And therefore, I might start practicing the intervention indirectly on the other 5 patients who are randomized not to get the intervention. So contamination is a big problem in many designs. And Marjorie's design by randomizing people by communities is one way to avoid contamination. Now, what's the downside of contamination? The downside is you don't get the randomization that we would expect on a patient level. If I go back to Marjorie's first table, remember we mentioned that the 2 groups she's going to be comparing, people in the Ohana support group, by here, versus the people in the standard intervention group, the 75 people who got the model intervention, the new intervention, versus who got the standard intervention. Notice they're not similar people. One group is older, standard intervention group, than another. If you randomly flipped a coin, you had 147 people. You would expect the coin flip to give equal number of old people in each of your 2 arms, equal number of young people. You would expect the age distribution to be very similar if you randomize people. The 72 people in one group would be roughly similar in age to 75 people in another group. We didn't get that because we didn't randomize people. So randomization of people gives you our 2 comparison groups on the people level, which are very, very comparable. And that's what Marjorie did not get. Marjorie would probably still have to, in the analysis, correct for differences in ages, correct for differences in body mass index, control for these factors in the analysis, where she would not have had to do that if she had randomized people, probably. So there are some clear advantages and some clear disadvantages to randomizing groups versus randomizing people. And here she randomized groups probably to avoid the contamination problem. Next point I mentioned is she originally approached 259 individuals to be in this study. Only 147 agreed to be in it, and only 132 that she initially asked to be in the study. Is this a problem? Does it affect generalizability? Does it affect validity? Well, it's hard to say. If her 132 people are a random sample, 259 people she started with, then chances are her study is valid, and chances are her study is generalizable to all 259 people because she has 132 typical people randomly selected from the 259 if people who complied with the follow-up and also agreed to be in the study are just like the people who didn't agree to be in the study and didn't complete the follow-up. But on the other hand, if these 132 people are different than the people who weren't in the study, then you could have a bias problem, and you could have a generalizability problem. So it's hard to say whether you have a problem with only enrolling 132 of the 159 people in terms of generalizability. In terms of validity, the fact in a randomized trial, usually validity is something that you're going to have. We'll talk about validity a lot next week. So I'm less concerned about validity in this study. I'm more concerned about generalizability. I'm more concerned that the people she enrolled in her study might be different from the people who didn't agree to be in her study. But chances are, if she properly controls for these imbalances in these studies, or in general, randomization on an individual level tends to give you valid results. And we'll talk more about validity next week. How comparable are the two comparison groups? Not that comparable with respect to age, not that comparable with respect to body mass index, as we mentioned. And that's a problem in this study. What are the advantages or disadvantages of using a standardized intervention rather than using nothing? Another design would have been take these two communities, choose one of them to get the Ohana support mechanism, and do nothing in the other community. Now, first of all, that might be an ethical problem. And especially in a clinical trial, it might be difficult to do a study where one group of people get a treatment and the other group get nothing. So usually people get standard of care. But the other reason for giving the control group a standard intervention is that now both groups are realizing that something is happening to them. So the fact that something is happening to you might influence whether you stay in a study or not, might influence how you react when people ask you questions about your outcomes. And the fact that both of these two groups are getting something, both of them are getting some intervention, will at least give you two groups of people who are in a similar mindset once the study is completed and once you start asking them about outcomes. Everybody knew that something was done to them. Everyone knows they were in a study. And therefore, that's going to have an equal influence on both groups of people when you ask them about the outcome. We'll talk about that use of a comparison intervention rather than no intervention in a few seconds. Okay, so that's all I wanted to say about Marjorie's study. Let's back up and let's say a few things in general about experimental studies. And here are just some of the key steps I think are involved in any experimental study. You start out by specifying a hypothesis. And that usually is separated into primary goals that you want to address and maybe some secondary goals, aims that you're trying to address. The primary aim might be whether your new intervention improves some important outcome, like survival or developing diabetes. Secondary intervention might involve, secondary hypothesis or aim might involve secondary outcomes, whether the person had better quality of life, for example. Once you decide on your hypotheses, your goals of your study, the next thing you do is you develop a study proposal, like you've been doing for homework for the last couple of weeks. Then the first thing you have to do is bring that proposal to an institutional review board, an IRB. Every hospital, every university in the States has one of these committees, which approves the research done at that hospital or approves the research done at that institution. So if I want to do a study in my hospital, Brigham and Women's Hospital, I have to bring my proposal to a committee in the hospital known as the hospital IRB, the Institutional Review Board. Their purpose is to make sure the study is ethical, primarily, and to safeguard the participants in that study, to make sure that no harm is being done to them in an unethical way. They're also charged with looking at the design and seeing if it has features which you would say make it a valid study, because no one's going to improve a study being done in their institution where this committee realized